हाँ।
ठीक।
क्या हो गया?
नहीं वो पूछा हूँ, लगा दिया ना। बिट्टू
भाई दे रहा
कहाँ हो?
है।
कहाँ हो? एक बार नीचे वाली को आ जाइए, जल्दी आओ।
Good morning, sir. Good morning, sir. Good morning, sir. Uh, Presenting a thesis topic of acute hemodynamic response to carvedilol predicts survival in ACLF patients, XC-ACLF study. Outlines. Uh, in ACLF patient, there is a underlying CLD with acute hepatic insult with alcohol-associated liver disease, HBV reactivation, AIH flare, viral hepatitis, Wilson flare, delay with post-surgery, post-stays, and post-stay with hepatitis A and hepatitis E. Within the 4 weeks, there is a rise in bilirubin of more than 5 and INR is more than 1.5 with ascites and hepatic NCAP with extra hepatic organ failure leads to ACLF. In ACLF, there is a two types, type A and type B, with a partial definition with liver failure with bilirubin and INR with acute hepatic insult with organ failure with and without hepatic failure with first presentation with or without cirrhosis with ARC grade 1, 2, and 3. And type B with CLIF grade 1, grade 2, and grade 3 with organ failure of liver, coagulation, brain, renal, circulatory, and respiratory and gut. This is pathophysio of cirrhosis and portal hypertension with brief, likely dynamic and structural changes in the endothelial stellate cell, increase in the contraction with extracellular fibrosis leads to increased hepatic venous resistance, cause portal hypertension. This is the sinusoidal epithelial cells with hepatic stellate cell with contractile proliferative and fibrotic factors with hepatic macrophages with polarized contractile pro-inflammatory and pro-thrombotic leads to liver microcirculatory dysfunction that lead to structural changes and vascular disturbances leads to increased hepatic venous resistance leads to portal hypertension with increased portal blood flow and splenic vascular cell dysregulation with vasodilatation and angiogenesis. In SELF, there is a unique additional mechanism with gut liver axis and systemic inflammation, circulatory pro-inflammatory cytokines, TNF alpha, IL-6. That leads to decrease endothelial nitric oxide synthesis with increased hepatic vascular resistance. In the gut and liver axis, there is increased intestinal permeability with massive bacterial translocation with systemic inflammation, spikes portal pressure. With dynamic components are a portion of portal pressure in ACLF with active vasoconstrictor of hepatic sinusitis and fibrosis. Hepatic venous portal gradient. HVPG is a gold standard for portal pressure. It's a measurement with wedge hepatic venous pressure minus free hepatic venous pressure. A threshold of more than 10 mmHg defines clinical significant portal hypertension. Values more than 16 mmHg are strongly associated with mortality, and more than 20 mmHg predict early varicose rebleeding at death. This is the foundation studies with hemodynamic criteria of recurrent varicose bleed and portal pressure hemodynamics. In this pressure decrease of HVPG is more than 20 in the first year, second year, and third year is decreasing with pharmacotherapy, and probability of rebleeding are more in the decrease of HVPG less than 20% in 66% during third year. More than 20% is a reduction from the baseline, with the therapeutic goal of hemodynamic response is the key: reduce risk of varicose hemorrhage, reduced recurrent decompensation with improved transplant-free survival. In this study, there is a comparison of carvedilol and propranolol to decrease the HVPG. In this, carvedilol around 20% is the mean HVPG decreased, with no major increase in adverse event with moderate doses. Our institute studies treatment with carvedilol improves survival of patient with ACLF with RCT trial. In this study, there is a carvedilol versus placebo group was there with in ACLF with decreased mortality, varicose bleed, and non-bleeding complication SBI, AKI with decreased risk to primary mortality, carvedilol to 10.62 and placebo of 24.3 with 13.6 to 35.7% with placebo. In SBP is also decreasing the carvedilol 6.1 with placebo of 21.4%. Carvedilol improves the survival and reduce AKI SBP events during the first 28 days in the ACLF patient with high HVPG. Lacuna in the literature is no study has examined acute HVPG response to carvedilol in ACLF. Acute hemodynamic response threshold from cirrhosis are not validated in ACLF. No data links acute HVPG fall to 28-day transplant-free survival. Safety of carvedilol in ACLF is unstudied. HVPG is dynamic in ACLF. Acute hemodynamic response is completely unexplored as a functional biomarker. Guidelines give no recommendation for acute hemodynamic response in ACLF. With hypothesis of thesis is acute HVPG reduction after oral carvedilol 12.5 mg predict 28-day transplant-free survival in ACLF. Aim is to determine whether acute hemodynamic response to carvedilol measured 1 hour after 12.5 mg dose can predict short-term outcomes in ACLF. Objectives is primary objective to assess whether acute HVPG change predict 28 days transplant-free survival. Secondary objectives are complications, portal hypertension related bleed, AKI, infection, hepatic ANCAP, hypotension, and cardiac side effect within 90 days. Transplant-free survival rate 890 days. Correlation with evolution of ARC score by 2 weeks. This is single center interventional cohort study with duration is 3 months. Sample size is 100 patients with 80 Inclusion and exclusion criteria. Inclusion criteria: patient 18 to 70 years with diagnosis of ACLF as per APASL criteria with a baseline HVPG measurable. Exclusion criteria are hemodynamic contraindication to non-selective beta blocker, heart rate less than 65, BP around 110, 70 below, AKI stage 2, 3 with serum sodium of less than 125, with massive ascites, grade 3 ascites, hepatocellular carcinoma, portal vein thrombosis, Busch-Chiari syndrome with HE grade 2 to 4. Others are non-selective beta blocker used within the last 5 days, bronchial asthma, heart failure, pregnancy or lactation, plant liver transplant within the next 12 weeks, and refusal for consents. Primary endpoints are 28-day transplant-free survival. Secondary endpoints are 90-day transplant-free survival with development of complication, varicose or non-varicose bleeding, AKI, hepatic NKF, hypotension, correlation between acute hemodynamic response and ARC score evaluation, safety profile of single-dose carvedilol in ACLF. Sample size is sample size is to evaluate the predictive accuracy of acute HVPG change for 28-day transplant-free survival. Assumption are expected predictive accuracy of area under curve is 70% with type 1 error is 0.05 with power 1 beta is 80% with dropout rate of 20%. Total sample size required 100 patients. This is consort diagram. With ACLF with baseline HVPG measurement, give after 1 hour to carvedilol to per oral 12.5 mg, showing repeat after 1 hour, follow up for 28 days, survived in death, follow up for 90 days and survived, and 28-day transplant-free survival and secondary endpoints are there. Statistical analysis, where baseline parametric data will be expressed as a proportion mean plus minus standard deviation and median with interquartile range. Here t-test will be used to compare the change before and after intervention. Pearson correlation test will be used for assessing the correlation. Multivariate logistic regression will be used to find out the predictors of transplant-free survival with less than 0.05 p-value considered as a statistical significant. Results of the showing are baseline characteristic in the studies are showing age in the younger patient, that is more in the age. Other than no baseline demographic profile are insignificant. In etiology, mostly alcoholic patients, alcoholic related cirrhosis patients are there in ACLF around. This is the clinical grades in survivor and non-survivor patient with ascites, HE and varicose grade. In ascites grading, last 10 ascites patient are more higher mortality groups are there, more in grade 3 10 ascites death. With HE grade 2 hepatic NKF grade 2 non-survivor are significantly more likely to present with grade 1 and 2. And varicose grade, there is a small varices were present in 60% of those who did not survive. Baseline characteristic in elastography in LSM and splenic stiffness with no significant, but one arc is significant in the in this study in the 6.2 plus minus 1.6 and 7.35 plus minus 1.7 in the death group. And the baseline characteristic of pre-HVPG, there is no significant in the alive and dead patient. This is same. This is lab parameters, baseline characteristic with significant in the hemoglobin. This significance of the hemoglobin in the death is less in non-survivor patient is 8.6 and non-survivor in 7.58. Decrease in the hemoglobin, increase in the TLC count is significant in the non-survivor. And third is serum alkaline phosphate is also significant in the death. In this slide showing acute hemodynamic response of carvedilol and survivor and non-survivor 28-day outcomes. In the pre-HVPG, there is a in survivor and non-survivor, there is a no significant in the baseline pre-HVPG. In the post-HVPG and HVPG reduction, there is a survivor is 13 and plus minus 4 with non-survivor 16 plus minus 5 with post HVPG significant result are there with the percentage of HVPG reduction is also there in the survivor is 31% with a non-survivor in 14%. This is also showing 28 days outcome survivor and non-survivor acute hemodynamic response ROC curve for acute HVPG response predicted 28-day mortality.
Can you go back? What is the number of patients in whom hemodynamic response came? Number of patients.
Yes, sir.
How many patients had alive or dead is not important. How
Yeah.
many had HVPG response?
Sir,
What your total?
sir, आगे slide is
Okay.
ROC curve of acute HVPG response predicting 28-day mortality with optimal cutoff of percentage HVPG reduction is 20.68% with significant p-value with positive predictive value of 87.8% with the sensitivity of 73 and specificity of 70.5%. So, acute hemodynamic response of carvedilol with alive and dead was acute HVPG reduction of more than 20.6 reduction in 42% alive at 28 days and non-survivor in 7 patients with death at 28 days with less than 20.68 reduction of alive in 23 and death is 16. Around reduction less than 20.68, sir.
Yeah, is it the number of patients? I just want to know out of your total,
Yes,
how many had response?
sir, 42%, 42
Out of
survivor
how
patient.
many?
49, sir, total.
So where is the percentage of the total patients? You have responders out of total. What is your total? मुझे यही समझ नहीं आ रहा है.
The total is 88, sir.
तो 88 में से कितनों में HVPG response है?
So 49 में more than 20.68 reduction हुआ है सर HVPG का सर.
Considered response.
Yes, sir.
Oh,
Yes, ma'am.
go ahead.
With Kaplan-Meier curve with by acute HVPG response with 28-day outcomes. With responders more than 20% reduction is 85% with 85% with significant responder and non-responder is less than 20% reduction in HVPGs, only 55% in the 28-day outcomes. This is acute. This slide shows post carvedilol with different HVPG and composite HVPG response with less than 12 mg and more than 12 mg after giving post carvedilol. Is 26% of non-survivor patient is less than 12 mmHg decrease with more than 12 mm post carvedilol HVPG shows 73.9%. In composite HVPG response with responder group more than 20.68% reduction or HVPG less than 12 mmHg with showing survivor in the 47 with patient and death of 8, total 55 with non-responder of 33 patients. This is significant is there. The post-procedure hemodynamic adverse event, only 3 patients showing bradycardia at the time of procedure. Others not, no hypotension, no AKI was there. So 90-day survivor is stratified by acute HVPG response more than 20%, less than 20%, showing responder and non-responder around 40 and 9 patient, 40 is survivor patient and non-survivor is 9, around 31%. Total is 49. Less than 20.68 is a non-responder with more 69% of non-survivor patient around. This is Cox proportional hazard analysis of 28 days initial in the 1 month. With there is a univariate and multivariate. Univariate variables are significant are HVPG reduction, hemoglobin, TLC count, lactate, serum sodium, age, IL-6, and SEP, and melt sodium. In this HVPG reduction and TLC counts are independent predictor, I think. With the multivariate HVPG response and lactate are independently predictor of survival versus non-survival in the ACLF patients with significant p-values. Here in the Cox proportional hazard analysis of 90 days, in this also in the univariate HVPG reduction, hemoglobin, TLC, lactate, ARC score, sodium, MELD, Na, IL-6, and SEP, there is a significant there, and multivariate there is a HVPG response, and the lactate there is a showing survival and non-survival independent predictors. Evolution of ARC score in survivor and non-survivor at 28 days. In this, there is a baseline ARC was survivor and non-survivor as 9.2 plus minus around the 1 to 4 weeks. And in the non-survivor, there is an increase of ARC score to 10, 11 in the 3 weeks to 2 to 3 weeks. Carvedilol dose and serum creatinine with between groups of comparison of 28 day survival. In the alive survivor group, there is a carvedilol and creatinine. Carvedilol is titrated with time with 1 week, 2 week, and 3 week. After giving 12.5, almost there's an increase of creatinine around 1.06 with 1.15 around the 4 weeks, with increase to 2 month 1.64 in the survivor group. AKI is presenting around the time with titrate the dose of carvedilol higher dose, and in the death there is a around 2 to 3 weeks higher the dose giving not tolerated creatinine was increasing in non-survivor group. Acute reduction in HVPG following single oral dose of carvedilol is a strong independent predictor of 28-day and 90-day transplant-free survival in ACLF, whereas baseline HVPG is not. HVPG reduction of more than 20.68% derived by ROC analysis with early mortality risk and mirrors traditional hemodynamic response definition of cirrhosis. Carvedilol is poorly tolerated a long time longitudinally in ACLF patient with frequent dose interruption and discontinuous predominantly driven by worsening renal function even among survivor. This finding the groundwork of for future studies evaluating personalized portal hypertension management in this high-risk population. This is the take-home message is acute HVPG reduction after a single oral dose of carvedilol independently predict 28-day, 90-day transplant-free survival in ACLF. With baseline HVPG does not discriminate outcomes. With dynamic hemodynamic response is prognostically superior. HVPG reduction more than 20.68 is the optimal threshold identifying patients with significantly improved survival. Non-responder to carvedilol has markedly higher early and late mortality. With acute, carvedilol testing is safe in selected ACLF patient through long-term use is limited by renal dysfunction. Thank you, sir.
So what does it mean anyway? Comments from the guide, please.
This is the preliminary analysis of the data that the study was done. And as far as the cirrhosis is concerned, only 2 studies are there for the acute hemodynamic response in analyzing the response to IV propranolol. In that, the 10% cutoff was found. And in this study, quite interestingly, the 20% threshold rule that holds true for the cirrhosis patient is validated here in this study also. 20% reduction, if it is there to the acute carvedilol dose, then it predicts nearly 85% chances are there that the patient is going to survive for 28 days.
Very important, very difficult and important study.
Yeah.
I'm still not clear. Why did you divide between alive and dead? You should have given the hemodynamic response in all the patients together. Combine 68, whatever, 88 patients together, then divide responders and non-responders to hemodynamics, and then see alive and dead. Is that what you have done or no?
So this is not the validation of the 20% threshold HVPG reduction. In this study, alive versus dead, they were there at the 28 days. And then we had seen what was the difference in the HVPG reduction in those patients compared to alive versus dead. So based on the AU-ROC, the 20% threshold was validated, in which it was found to be having maximum AU-ROC with the maximum sensitivity and specificity.
Out of the total response, those who responded were 42 out of 49. Am I right?
Yes, sir. 49, sir.
42 out of 49
Like
survived.
88.
Yes, sir.
Of the
Yes, sir.
total
49 had
49, sir.
response.
49, so 7 out of 49 responders also died.
Yes, sir.
Why?
So the AU-ROC was not 100%. It was 0.76, 0.74.
And those who did not have reduction, even in them, 23 survived. So we just need to see what are the characteristics of those who survived despite inadequate reduction versus those who had a good reduction. I hope I am making it clear. 7 and 23 are the odd.
So 16.
16.
16.
Yeah, 16 and 7. So why 16 and why 7? And are there any other variables? And for that, you should look into the inflammatory markers
Yes, sir.
and others. And lactate. Did lactate, what was the weightage of lactate? That should be another.
Sir, higher lactate is independent for predictor survival. Higher lactate is
Part
always.
of ARC. That is part of ARC.
Yes, sir.
So
AU-ROC gave you what?
20%. This is
That is from that sensitivity and specificity.
yes.
What sensitivity and specificity?
Maximum sensitivity and specificity.
Is it the sensitivity which is more important for you in this first test? I think that's important. See, that important point here is that do you want true negatives to be the best here or true positive? If I'm saying wrong, then please somebody correct me. But is it sensitivity and specificity? Which one do you want better?
We want sensitivity more. We want to identify who are the patients who are going to survive, who are the responders, and they
let
should be having
the
maximum sensitivity.
student to respond, please. तुमसे सवाल पूछा जा रहा है.
Yes.
I think the question would be the sensitivity and specificity that you have taken here. Maybe that cutoff of 20 is not right, and then sirs, a question will be answered. Maybe if you change your cutoff, then this 7 here and 23 there may change.
Even in the Lancet study, in which the 20% cutoff was identified, 1995, the sensitivity was close to 100%. The specificity was only 52%. Because we want to identify who are the patients who are.
Is it the other way around?
No, the responders should survive. We want to identify who are the patients who are going to survive. And if there is chances that these patients may not be surviving because these are high-risk patients, then we can have a backup plan of liver transplant in these patients as well.
Garvit, can you show pre and post carvedilol cardiac parameters? Cardiac parameters.
And this is one pre, sir. Post
Pre and post cardiac parameters.
cardiac.
कि तुमने HUPG किया,
सर
पोस्ट PCWP वेज प्रेशर वो कहाँ है?
सर वो एक्स है तो सर एक्सेल में है सर।
Because
मैंने
you
इसमें
need to
बताया।
see post whether the heart responds, whether they have cirrhotic cardiomyopathy or any cardiac event,
Yes.
cardiac dysfunction, and that is the reason they have not responded. So pre and post in responder, alive and dead, what is the difference post carvedilol in their cardiac, pulmonary wedge and others?
Yes.
Any other comments? If not, thank you. Do we have a second thesis presentation?
Yes. Thank you.
What's the really big sensitivity and specificity?
Means appropriate cutoff should be there, considering both sensitivity and specificity. Because we should not miss the false positive as well as false negative.
Good morning.
We should not miss the deaths which may happen.
Good morning, everyone. My research topic is impact of near infrared spectroscopy, that is NIRS, NIRS-based goal-directed therapy for intraoperative hemodynamics on post-operative cognitive dysfunction. It is a single-blinded randomized control trial. So, as we all know, liver transplant is major surgery. Despite of advancement in surgical techniques, anesthetic management, and advanced post-operative ICU care, it is still associated with significant physiological stress and perioperative complications. So, common post-op complications includes graft dysfunction, infections, respiratory complication, neurological dysfunction, and AKI. Among these, post-operative cognitive dysfunction is a frequently encountered complication that affects post-operative recovery and patient outcome. So what is post-op cognitive dysfunction? Cognitive dysfunction is impairment in memory, attention, and execution of the function. So if in patient who had baseline better, good or normal cognitive function, if post-op he develops these impairment, then we call it post-operative cognitive dysfunction. So prevalence of POCD is 30 to 60% of liver transplant recipient in early phase, that is post-op day 7. In previous studies, identified risk factors are advanced age, pre-existing hepatic encephalopathy, baseline cognitive status, anemia, hepatic dysfunction as MELD score, systemic inflammation, intraoperative hypotension, and prolonged ischemia time. These factors cause impaired cerebral autoregulation, reduced cerebral oxygen delivery, which cause brain vulnerable to perioperative hypoperfusion and ischemia. Traditionally, we rely on macrocirculatory global hemodynamic parameter like mean arterial pressure, central venous pressure, and cardiac output for peri-op anesthetic hemodynamic management. These parameters may not accurately reflect microcirculatory perfusion at the tissue level, for example, brain level or kidney level. So a patient may have normal MAP with the use of high dose of vasopressor, but he can still cause regional ischemia at microcirculation bed as brain and kidney and other end organ. So in liver transplant, severe hemodynamic changes can occur, especially during massive blood loss, portal vein IVC clamping, and during early post-reperfusion period. All these things can lead impaired cerebral perfusion and cerebral oxygenation, which can result in post-op cognitive dysfunction and AKI. So, near-infrared spectroscopy (NIRS) has emerged as a non-invasive continuous monitoring modality for regional tissue oxygen saturation and provides a surrogate measure for regional perfusion adequately. So, cerebral NIRS monitoring has been extensively studied in other medical surgical population, including cardiac and high-risk non-cardiac major surgeries. So studies have found that optimizing anesthesia management guided by this NIRS intraoperative regional cerebral oxygenation, it significantly reduced the incidence of POCD within 7 days, especially in cardiac surgeries. So this monitor we have used in our OT setting. It continuously gives oxidation in number. This is for left and right. And simultaneously, it gives total waveform, total intraop trends of the oximetry from baseline to till the end of the surgery or till the end of the monitoring. And placement of the electrodes were done in both left and right forehead in frontal lobe. So research gaps are studies focused on the impact of NIRS-based goal-directed hemodynamic treatment on the incidence of POCD in recipients of LDLT are very limited. This creates a significant evidence gap due to high physiological demand of LDLT and the possibility that cerebral dysregulation could lead to neurocognitive dysfunctions. We hypothesize that incorporation of protocol-based cerebral NIRS-guided goal-directed therapy for intraoperative hemodynamics management is associated with decreased incidence of POCD following liver transplant. So our primary objective was to compare the incidence of POCD in NIRS-guided versus standard care group on post-op day 7 in LDLT transplant recipients. And secondary objectives are to compare incidence of POCD on POD in late post-op cognitive dysfunction, and to compare post-op AKI within 7 days of in both group, to compare ICU stay and hospital stay in both group, and to compare neuroinflammatory biomarker, neuron-specific enolase and S100B in both groups. So this study was placed in Department of Anesthesia, ILBS, after approval of IEC and registration in CTRI. We included all adult patients and 18 to 65 year age undergoing LDLT surgery. And we excluded patient who refused to give consent, patient who had acute liver failure, patient with previous neurological disorder like Parkinson, Alzheimer's, cerebrovascular accidents, patient who had pre-op AKI, and patient who had recent history of recent HE within 30 days before taking in the OT. So our sample size was calculated based on the Kolek et al., who observed approximately 27% reduction in POCD when they done intervention based on NIRS. So we hypothesize that implementing a combined NIRS hemodynamic algorithm to maintain cerebral oxygenation at the 20% of baseline would reduce the incidence of POCD to 7% in intervention group. So according to this, we calculated the sample size and minimum 33 patients per group was required. And to account for 10% attrition rate, considering LT has associated with high peri-op mortality risk and potential loss to follow-up, the total sample size was finalized 40-40 each group, that is 80. A computer-generated random sequence with block size of 10 was used for allocation. Patients were randomized in 1:1 ratio in two groups. N group, that is NIRS guided therapy group, number is 40, and S group, standard anesthesia care group, number was also 40. This study utilized a single-blind study design in which participants were blinded to their group allocation. But due to the nature of intervention, the treating anesthesiologist was required to actively respond to a specific parameter in the intervention group. It was not feasible for us to blind treating anesthesiologist for the group allocation. So anesthesia was induced as per institutional protocol. Standard monitoring was used. Apart from the standard monitor, 2 cerebral oximetry electrode were placed in forehead after intubation in all patients, as I have shown in picture. In the standard group, hemodynamics were managed as per standard protocol. A cerebral oximetry monitor was attached and covered with drape. The treating anesthesiologist was unaware of cerebral oximetry value, but later on, retrospectively, we collected the data of their NIRS value. In the N group, along with above mentioned parameters, cerebral oximetry value was also targeted within 80% of baseline. An intervention was done as per the preset algorithm. The algorithm was whenever NIRS fell by 20% of the baseline, in step 1, we increased mean arterial pressure by 10 mm Hg using first 2 to 3 ml per kg fluid boluses, and if there no response from boluses, then move to vasopressor. If within 60 seconds there is no improvement of NIRS, it did not reach to the baseline, 80% of baseline, then we went to step 2. So in step 2, we increased the FiO2 by 10%, maximum up to 70% to avoid the oxygen toxicity and hyperoxemia related complications. If still NIRS did not reach to the base, 80% of the baseline in 60 seconds, then we done ABG. And if we saw that hemoglobin is less than 8 gram per deciliter, PRBC was transfused to maintain a target of equal or more than 8 gram per deciliter. And simultaneously, PSO2 was observed when ventilatory setting was adjusted to keep PaCO2 35 to 45 mm of Hg. If patient are still not responsive, then we ruled out any surgical clause that prolonged portal vein clamp or IVC clamp time. Even after all this intervention, if patient did not reach up to the 80% of baseline value, those patients were labeled as non-responders. This is a flow diagram of our step-by-step interventions. Data collection, we noted heart rate and mean arterial pressure in 8 distinct surgical phases: baseline, dissection phase, anhepatic, IVC clamp time, immediately after reperfusion, 30 minutes after reperfusion, 2 hours after reperfusion, and before shifting to the ICU. Similarly, NIRS was monitored continuously, but for analysis is noted at all these 8 distinct phases. Surgical metrics like intraoperative blood loss, duration of surgery, warm ischemia time and cold ischemia time, graft weight to recipient weight ratio was recorded. And baseline and 2 hours after reperfusion, a 3 ml blood sample for serum biomarker, NAC and S100B protein was sent for every patient. The cognitive function was assessed at baseline, post-op day 7 and post-op day 28 based on this Montreal Cognitive Assessment Score. So this is a pro forma for Montreal Cognitive Assessment cognitive function. So this consists different domain: visual, spatial domain, memory, attention, language, abstraction, recall, and orientation. So total score is 30. But MoCA score is less than 26 at day 7 or day 28 post-transplant were used to define the presence of POCD. Similarly, the incidence of AKI within first 7 days of post-operative days was defined and staged according to KDIGO criteria. Statistical analysis was continuously variable were expressed in mean and median depending on the distribution and normality. Categorical variable were expressed as as a count and percentage, and comparison were performed using either independent sample t-test, Wells test, or Fisher Wells test as per requirement, and Fisher exact test and chi-square test to determine significance. So this consort diagram for study, we assessed for eligibility 122 patients. Then 42 patients were excluded in view of 19 patients were pre-op AKI, 9 patients were have baseline impaired cognitive function, and 14 patients were unable to perform this MoCA test. So 80% were included, and they are allocated in 2 groups. N group in where intervention were done, and in standard care group, and both number of patients were equal, 40 and 40. We followed a patient for 28 days, but in intervention group, 3 patients we lost because they were on mechanical ventilation. So we could not assess for post-op primary objective POCD. And similarly, in standard group, 4 patients were excluded because of they were on mechanical ventilation. So finally, in analysis, in N group there were 37 patients, and S group there were 36 patients. So total of 80 patients were enrolled, and 3 patients in N group and 4 patients in S group were on mechanical ventilation on post-op day 7. So they were excluded from analysis. And final analysis was done in 73 patients. In N group, 48% had a fall in NIRS and required intervention, and 5% did not respond to any intervention, and they were labeled as non-responder. In standard group, 58% patients had fall in NIRS. So baseline characteristics like demographics, degree of hepatic decompensation, and intraoperative surgical metrics like blood loss, duration of surgery, ischemia time, they all are comparable. So our primary outcome was POCD at post-op day 7. So in N group, there is intervention group, it is 16.2%, and in S group, it is 41.7%. That is clinically significant, statistically significant. And secondary outcome, POCD on 28 days was comparable, AKI within 7 days was comparable, and significance in total ICU days was shorter in intervention group, which is statistically significant. However, hospital days are not significant, and we did the neurological inflammatory marker, but for the patient group are different in this for this analysis. This NAC was compared between patient who had POCD and who did not have POCD to compare its relation with a neurological marker relation with POCD. So intraoperative hemodynamics, as we can see, we have managed a patient with intervention group has higher mean arterial pressure during dissection and hepatic at IVC clamp and immediate reperfusion phase. And similarly, comparison of mean NIRS value in intervention group at the IVC clamp phase, there is significant higher NIRS value was shown. So this is a map mean arterial pressure trend in two different phases of surgery in two groups. So here we can see in dissection phase and hepatic phase and IVC clamp and immediate reperfusion phase, intervention group has higher mean arterial pressure because we maintain higher pressure to maintain NIRS. Similarly, comparison of mean intraoperative NIRS value in two groups. As we can see, as IVC clamp phase, intervention group has higher cerebral oximetry values. So we plotted correlation graph between mean arterial pressure and NIRS at IVC clamp phase. So we found statistically significant weak to moderate positive correlation. So we did post-op day 7 POCD, significant predictor for post-op day POCD, which is significant was age, prior HE, baseline hemoglobin, and group allocation. These were a significant risk factor in univariate analysis. And in multivariate analysis, same prior history of HE, age, baseline hemoglobin, and group allocation were significant risk factor. So we plotted ROC curve to determine the cutoff. So HB of less than 9.25 and age is more than 5.5 with sensitivity of 52.4% and specificity of 88% was a risk factor for post-op cognitive dysfunction. So our result demonstrate that incorporation of NIRS monitoring and targeting shows a significant reduction in POCD in post-op day 7 and shorter ICU length of stay, that is 66 versus 10.2 days in both groups. However, there is no significant difference in incidence of post-op day 28 and acute kidney injury between both groups. So multivariate logistic regression also confirmed that group allocation is an independent protective factor along with higher base in hemoglobin, while advanced age and prior history of encephalopathy were identified as a risk factor for the POCD. So prevalence of POCD after LT is around 30 to 60% in various studies. Interventional studies for cerebral oximetry targeting and its impact of early POCD were not well studied in liver transplant, but it was extensively studied in cardiac and other major surgery. So in 2020, Ussel et al. Reported in randomized control trial that goal-directed optimization of cerebral oxygenation can resulted in significantly improved cognitive score compared to standard care after 3 and 6 months of postoperative period in cardiac surgery. Similarly, in spine surgery, Trefidlo et al. Found that intraoperative NIRS monitoring and appropriate intervention as per according to NIRS led to significant better postoperative cognitive performance in early period. So during anhepatic phase and IVC clamp phase, the interruption of portal and cable flow can lead to significant drop in cardiac output and as well as cerebral perfusion pressure. During the reperfusion of graft, there is surge of inflammatory cytokines, vasoactive substance, and potential emboli to the systemic circulation, which can disrupt the blood-brain barrier and trigger neuroinflammation, which is a key driver to the cognitive impairment. So in contrast to significant benefit observed in early post-op period, the incidence of POCD at day 28 was comparable between two groups. This suggests that impairment observed at day 7 was likely functional and reversible, and it was caused by transient intraoperative hyperperfusion rather than permanent neuronal damage. This also reflects in our neuronal injury biomarker NEC and SNRB because the damage is at the functional level, not at the cellular level. So in our study, we found that there's no clinical difference in delta neuron-specific analogs, that is baseline, post-reperfusion and minus baseline, but not statistically different. So multivariate logistic regression analysis found that an advanced age and history of hepatic encephalopathy emerged at significant risk factor, with prior HE being the strongest predictor for poor outcome, odds ratio 5.64. Hepatic encephalopathy reflects chronic disturbance in cerebral metabolism and neurotransmission, which may impair compensatory mechanism during the period of reduced cerebral perfusion and makes brain pressure dependent. Incidence of post-op AKI within first 7 days following LT was comparable in both groups. Post-operative AKI is multifactorial. It depends on MELD score, intraoperative hemodynamic stability, massive fluid loss, and nephrotoxic drugs exposure. So the NRS carrier group experienced significantly shorter duration of ICU stay compared to the control group, 66 versus 10 days. Patient without may be contributing factor to the shorter prolonged ICU stay, because patient with neurological impairment were typically without neurological impairment are typically more cooperative and can be mobilized more rapidly. Similarly, meta-analysis done in 2022 confirmed that cerebral oximetry guided management is associated with reduction in ICU stay across multiple non-LT major surgical population. However, we did not observe any significant difference in total hospital length of stay. The limitation of our research is due to nature of the intervention. Blinding of the treating anesthesiologist was not feasible, which may have introduced performance bias, and longer follow-up would be needed to evaluate persistent neurocognitive outcome beyond 28 days, which we did not do in our study. So in conclusion, our randomized control trial demonstrated that NIRS-guided hemodynamic management significantly reduced the incidence of post-operative cognitive dysfunction at day 7 and shortens ICU stay, although it does not appear to influence renal outcome and long-term hospital discharge. Furthermore, the identification of advanced age, history of HE, and lower baseline hemoglobin as independent risk factor allows for better risk stratification, enabling anesthesiologists to prioritize neuroprotective strategy for the most vulnerable patients.
Thank you. Any comments from the guys?
Well, as we know that the postoperative cognitive dysfunction is one of the commonest problem after the surgery, and it has been very well reported even after the other surgeries. So why we thought of doing this study in the liver transplant patient is because these patients are quite at a higher risk when compared to the other patients. Since these patients are going to have a lot of hemodynamic fluctuations, and they're going to have invariably IVC clamping, which can lead to a decrease in cardiac output by almost 30 to 50%. So this decrease in cardiac output can ultimately lead to the decreased cerebral perfusion. So moreover, these liver transplant patients, they are in fact at more risk since they have a poor autoregulation of the cerebral blood flow. So these things make these patients very peculiar for the post-operative cognitive dysfunction due to the affected cerebral perfusion in the intraoperative period. And that is what we have found in our study. Because this study was powered to see the incidence of POCD on day 7, and it was not adequately powered to see the incidence of POCD on day 28. So maybe we can do in the further studies by increasing the sample size or by exactly calculating the sample size for looking the incidence of POCD at day 28 or maybe at day month 3, 6, and the 1 year, which is a more important POCD incidence when compared to the early POCD incidence. And the other important thing which we have found here is that the markers were absolutely normal. They were within the normal range in both the groups. So that again signifies that the changes were probably due to the small duration of hypotension episodes, and particularly the patients where the hypertension was associated with the anemia. They were in fact the more prone, which actually didn't come in the result. But this was our clinical observation. Patients who had a hypertension, and if they have a low hemoglobin at the time of hypertension, they were more prone to have a low NIRS.
Thank you. I was wondering, I might have missed, what was the baseline difference in the ammonia levels
We did not
in the
see.
patients who are going for transplant? Was there, maybe you can look into it, it might give some relevance. Many of these patients may have high circulating ammonia. They may also probably have an albumin which is low. So I think these two could also be, and if you can run a multivariate, it might help you, because suddenly putting a liver, it will not change his brain or change his albumin. So you can look into preoperative variables, whether they influence uh, in any way. And
Okay.
by you can look into it and
Yes.
run it into, and the NIRS between right and left, was there a difference?
No,
Right
sir.
side, left side?
They were comparable. We, as per the company standard, a difference of up to 20% between left and the right side is acceptable. So more or less all
Post-operatively and pre-operatively, did it change? It's a curiosity. Pre-operative, NIRS on right and left. Post-operatively, NIRS on right and
So
left.
one thing which we have observed, in fact, this is actually in continuity of the previous study. So in the previous study where we just
Can
try
the
to find,
student, sorry, Gaurav,
yes,
Sir,
can she,
in intraoperative period, there's also one problem that we use a center line and wide bore sheath in the right side. So venous condition, little venous condition can happen. So maybe right side of NRS value may little different, but within as our company protocol, within 20% of difference can be acceptable.
no, I'm not saying right, left. Pre-operatively, what was the right and left NIRS on the two sides? Post-operatively, you can look into it, you don't have to answer.
Okay,
Any other comments?
Sir. Hi, Nidhi. Very good. Well done. Gaurav, well done. In the whole team, very well. I always believe. Okay. So, very good study. This is something I always believe.
I request everyone to stay back. There is a World Kidney Day function which Dr. Mathur has organized. So please stay for a few more minutes. And we have Mr. Vikas Swarup coming here. So I think it would be worthwhile. Those who can should.
So, very nice study. This is something I always believe actually, because this is one operation which is a long operation. It takes about 12-15 hours on table. Then lots of hemodynamic instability and maintenance of a good mean arterial pressure during during that phase is the most important thing. And this is one comorbidity which affects lot in terms of post-operative. What is going to happen in the immediate post-operative period? Because if patient doesn't wake up properly, then you have respiratory issues, then sepsis and all those things comes in play. So documenting all this actually is a very good study, to be honest, because this is a good contribution to the science. My only thing is, like Sir said, pre-operative evaluation, I think if you add that data into especially shunt part, whether the patient, this was a patient who had shunts, and was there a difference between shunt and non-shunt patient? So we will have that data actually, because we have shunt documented in all patients. So obviously shunts are the one which have more hepatic encephalopathy, more chances of cerebral atrophy, and whether they behave differently during on this neurological monitoring as well. So that will be a good contribution to your data. But this is a good study actually documenting that you need to maintain a good mean arterial pressure during the operation for a liver transplantation. That's the crux.
Thank you.
Good. Well done.